Good afternoon, everyone. I'm Dominique, and I'm going to be presenting one of the studies that forms part of my PhD. And the topic is targeted functional movement retraining to improve pain function and biomechanics in subjects with anterior knee pain. Just a bit of background to start off with. Anterior knee pain affects up to half of young sports participants. It impairs functional ability and it has a tendency to be chronic. So it's estimated that 91% continue to experience symptoms 4 years after its onset. And these symptoms hinder activities of daily living and sports participation. Functional movement retraining, just to describe my intervention, it's an approach to rehabilitation that focuses on quality of movement and neuromuscular control and aims to achieve functional stability. So what we're attempting to do here is to correct a movement pattern as opposed to targeting specific muscle groups. And it's based on the law of specificity. And this law states that in order to achieve maximum training benefits, muscles should be conditioned in a pattern similar to which they are to perform, including the exact pattern of movement. There have been promising results from 2 lab-based studies looking at this approach on runners with anterior knee pain, but no research has been done to assess the effect of functional movement retraining during other activities such as squatting and stairs and gait. And these are activities that often reproduce the symptoms or aggravate the symptoms. So the aim of this study was to assess the effect of a subject-specific functional movement retraining intervention on subjects with anterior knee pain. And secondly, it was to conduct a case series on a subsample of 8 as a pilot for a larger study. So it was to assess the feasibility of the procedures. The research setting, the motion analysis was done in the Tygerberg Motion Analysis Lab, and the physio interventions were done at the Tygerberg Campus Physio Clinic. The method's targeted functional movement retraining intervention was implemented for 6 weeks. Gait analysis was done pre and post intervention. Pain was measured weekly using the numeric pain rating scale, and participants were required to keep a pain diary once a week at the same time of the same day throughout the treatment period. And then 2 functional scales were used, and these were the anterior knee pain scale and the lower extremity functional scale. And these measures were taken at the same time as the motion analysis assessments. Sample description, we had 8 participants, 3 males and 5 females between the ages of 18 and 40, residing in Cape Town. And that's just a chart to see test 1 was the motion analysis and the functional scales. Then there was the intervention period for 6 weeks, and then another test a week later at week 8. And our sample was based on, we have a diagnostic checklist based on a systematic review that we used to see if people met our criteria, participants. The decision-making process for the intervention. We considered the highest available level of evidence, and we had created, prior to the study, we had created an algorithm that can be used by clinicians for risk factor identification, and this was a study on its own. And the interventions were targeted to address the risk factors that each subject presented with, so it was individually tailored. That's an example of the algorithm for gait. That's how we graded the risk factors according to whether the findings were consistent and significant from different studies. And this is a systematic review, based on a systematic review. The exercise principles, a database of exercises was created for different activities and to address different factors. So there was a database for hip, knee, ankle, all of the different factors. And the least painful activity was addressed first. And activities were chosen at an appropriate level of difficulty and progressed as necessary on a weekly basis. Intervention description, once a week for 6 weeks. Supervised by a physiotherapist, and then they were prescribed a daily home exercise program, which was unsupervised. The home exercise program was the same as the exercises done in the sessions. They were asked to do those by themselves. And these were updated weekly. Exercise quality and correction was encouraged by the use of verbal feedback and visual feedback. They did all of the exercises in front of the mirror so that they could see what they were doing and what they were correcting. So we had 3 main outcomes: knee kinematics, actually lower extremity kinematics. So it was hip, knee, and ankle and foot. We looked at peak angles for these outcomes, but the risk factors, we chose the main outcome for each participant, and that was what we analyzed for them based on our algorithm. For example, if knee flexion was their main risk factor, then that's what we would analyze for that participant pre and post intervention. Then pain, we had our pain diary and our functional scales. So results, pain levels during the treatment period. There was a decreasing trend, but there was some variation throughout the treatment period. And if you see, that's the average. But if you look at the individuals, you can see why there's that spike at week 5, because there's an outlier from participant 2. But overall, the pain did decrease. 7 out of 8 of our participants were pain-free at the final motion analysis assessment. And the other one was the same, so nobody got worse. But it's also important to consider that all of these participants had pain for 3 months at the time of recruitment. So pain might not be the best measure. Function may be better, because there could be central mechanisms at play. Functional scales, all of our participants improved in terms of function, all 8 for both of the functional scales, but clinically significant improvements were only identified in 2 for the anterior knee pain scale and in 1 for the lower extremity functional scale. However, this could just be because it was a high functioning group to begin with, so their scores were quite high at the baseline assessment. So they could have just had one activity that they were struggling with, and that could have improved. So it could still be important, even if it was a small change. Biomechanical results, clinically meaningful changes in 6 out of the 8 participants. 2 did not, and there was an association between biomechanics and improved pain in 6 out of 8 of the participants. Just a table, you can see they each have their own risk factor that's been identified. And then there's a pre-intervention measure, post-intervention measure, and the mean change in degrees. So the main lessons learned from this study, the results from this pilot suggest that functional movement retraining improves pain function and biomechanics in individuals with anterior knee pain that present with biomechanical risk factors. That's important because if they don't have a biomechanical risk factor, this approach isn't going to work. So it's for that specific subgroup. And therefore this suggests that this should be investigated on a larger scale due to these positive results. Single subject designs are needed because there is so much variation in the clinical presentation, etiology, and all of these factors, and so much intra-subject variability. It is important to compare subjects to themselves. And a one-size-fits-all approach is unlikely to be successful when treating a multifactorial condition such as anterior knee pain. Any questions? It was based on common aggravating activities. So there was a database for gait-based exercises, squatting, lunging, stairs.
Is that according to that systematic evaluation?
Yes.
What's a clinically significant biomechanical change?
Well, for the purpose of this study, we considered it to be more than 2 degrees because that could just be as a result of measurement error. But that is something that I plan to investigate further for the larger study because of it could be different for different outcomes. So 1 degree could be significant for the foot, but for the hip it might be 5. So that is something I plan to investigate further for the analysis of the main study.
Dominique, I'd like to know, you were talking about the hip. Would you go further up to lumbosacral problems causing a dysfunction at the knee?
For this study we didn't, but for the larger study I'm including trunk, everything up to the trunk. So that is a change that I made following this pilot.
Thank you very much, Dominique.